So, have we got Cathy on the phone? Okay, great. Those of you who are in the hallway, if you want to come on in, we'll start the discussion period. So, I don't know about the rest of you, but I was taking notes rather frantically during the morning, and there are a lot of good ideas and suggestions from this panel. Now, this particular time is the opportunity for us to have a conversation with the panel members, and I see Cathy's now up on the screen. Can you hear me okay, Cathy?
Absolutely.
Terrific. Can you see us?
Yes.
All right. We'll be careful about that then. So we have Cathy as well as the four panelists. Now we need to think about, obviously, what we've heard this morning individually, but also collectively. And what this period of time is our opportunity to do that, both to ask questions, but to engage this panel of very bright and smart leaders who've made some good observations, engage them in the conversation about what this opportunity is. I was personally struck by Harvey's emphasizing the expanding the tent aspect of our work, as well as some of the challenges here, and as well as the particular comments that the panel has made. So, those of you who have comments, there's a microphone in the middle of the room there. I'd like to see people, if you have a comment, begin to stand up and come to the microphone and make a question or a comment apparent. So if anybody wants to start off, we are now ready for that conversation. There we go. Thank you, Sandy, for starting the ball rolling. And please identify yourself. I know we all know you, but want to make sure that everybody knows what your question or comment's going to be.
Sandy Magnan from ICSI in Minnesota. Thank you all for your presentations. A number of you mentioned developing political will. So let's do what David asked Dr. Feinberg. Fast forward 3 years. We're at the end of this. What would developing political will have looked like for you, and any ideas about how to go about that?
Well, I think for starters, it would be in the general dialogue that we as a society are having, that this notion of population health, obviously not referred to with that terminology, would be something that people are openly talking about. Where on blogs or in general conversation, people are saying, well, it's obviously not to spend more money on hospitals and doctors' offices. We've got to, change the where we live and all that kind of stuff. To hear that not just coming out of the mouths of people who work in public health or social determinants, but to have that more of the general conversation. But particularly among policymakers, not to have the following experience. So just a quick anecdote. I published a paper a year or so ago about the budget cuts in Wisconsin and how cutting funding on education would be bad for health. And I called Capitol Hill, I think it was the House Energy and Commerce Committee. I wanted to talk to the staffer there who deals with education to talk about whether that kind of argument is helpful. So I called up, I said, this is Dr. Woolf, could I speak with the education desk? And she said, one moment, and there was music, and then somebody answered who was the healthcare desk. So I said, I meant the education desk. She said, well, call back the main number and ask again. So I called back. I said, this is Dr. Woolf. Could I speak with the education desk, not the healthcare desk? One moment, please. Music, healthcare desk again. So called back the third time, and I said, this is Steve Woolf. Can I talk to the education desk? Got passed right through. And what's interesting about that experience is we're still not there yet in terms of connecting the dots and understanding why would a doctor care about education. And so if our policymakers saw that connection more and are thinking about how do we drive down healthcare costs by cutting off the flow of disease into the system, by dealing with these upstream causes. I'd recommend Bobby Milstein's paper in Health Affairs a year and a half ago showing how that strategy actually bends the cost curve. So the more that became part of the policy conversation as well as the public conversation, I think we'd be in a good place.
Can I add to that? I completely agree with what Steve has said, but let me be concrete about some of the things I think we really need to think of. One of the things would be, and I'm building on, I think Steve highlighted this in his presentation, is that the average American would think of this as a national priority, that this is going to be something important to happen, and it's something that they will have a willingness and a commitment to see and take place. There's a growing body of research suggests that we really think with our hearts, and it's really our emotional connection to issues that drive our policy preferences, which one of the implications for that is those of us in the health field need to work a lot more with political scientists and a lot more with communication experts so that we can begin to develop the language that moves people. And this may not be as far-fetched as you might think it is. There has been a sea change in the United States in terms of attitudes towards gays and lesbians. It hasn't happened by chance. There's actually research that documents the specific strategies that have been implemented, many of them at a national level through media, that have shifted the connection and have shifted the attitudes of individuals, and therefore, as a result of shifts in the attitudes, there's shifts in policy preferences. Now, I'm not saying that the problem has been solved and that but there has been enormous progress. So just to give an example of how concrete this is and how much preferences drive, Thomas Pettigrew did a study in the Netherlands, England, France, and Germany, looking at attitudes towards immigrant outgroups in each of those societies. And what he found was one of the single strongest predictors of attitudes was answers to two questions. How often you feel sympathy for the group, and how often you feel admiration for the group. I replicated those findings in US data, working with James Jackson and other colleagues at the University of Michigan at the time, and we asked whites, how often you feel sympathy for blacks, how often you feel admiration for blacks. And we developed a measure of no emotion, no positive emotion. It was the single strongest predictor of whites' opposition to government support to help blacks, one, and whites' opposition to affirmative action policies and employment. And it was stronger than income, education, age, political party preference, liberal or conservative, their beliefs about the nature of inequality in American society, traditional prejudice measures, modern prejudice measures. These single predictor, just tell me how you feel about the group. And we need to develop narratives that help people to connect with the real struggles and experiences of others. America is a kind people. Look at the response that we make in response to disasters. Why? Because we connect with what others experience, and we need to find ways, and the technology exists, it can be done, we know how to do it. We just have never thought of moving the needle along those lines, of informing others, but in a way that they feel emotionally connected to the challenge and will be motivated to act.
So
Eduardo?
interestingly, I wrote down, and so I'm not going to spend as many words. I'm just going to say what we need is a communication strategy that's based on some of the research that's out there, some of the market-based research techniques that are used to understand why people think the way they do, and to begin to think about how it is that we change the way people are thinking about issues. Because it won't be enough to know that if you're neutral, then you would be opposed to policy. The next step is, how do you move from neutral to having more of a caring attitude? And there are plenty of organizations out there that are involved in not only selling product, but also getting the vote out. And it may be time to bring those to the table and begin to think about those strategies. And this has to be thought of in terms of thinking about those who are in the camp, But most importantly, back to the words that I was using, is figuring out how you bring the non-believers and convert them to believers and change the norm.
Steve?
Yeah, and I guess what I would follow on with this is to change the dialogue. When we talk about taking waste out of the healthcare system, that's not about rationing. And that what we need to do is to get people to understand that they need to live in healthy communities if they're going to be healthy. Everyone's entitled to a good education. Everybody's entitled to a good, safe, affordable home. Everybody's entitled to live in places with adequate recreation and transportation and jobs and so forth. And we need to change the dialogue and the frame of reference so that in terms that people can relate to and understand. I personally think that the Affordable Care Act came to be largely because people understood that everyone was entitled to a family doctor, not that we were providing care to those who didn't have it, but there was an entitlement that all of us have, and that we need to have that kind of a framing if we're going to move the understanding about what a healthy community is moving forward.
Cathy?
Oh, thanks. I think that I agree with helping people to feel the emotion around this, but I think in addition, we're going to have, if we're building will, we're going to have some consciousness raising to do with various multi-sectoral groups, and we need to help people to see the interdependence and the alignment of how these population health objectives and goals are actually helpful to their own objectives and goals. So the people whose mission it is to try to improve education and help us build the alliances with them. So I think we'll raise consciousness, build alliances, do outreach, and we'll see it manifest when the goals and the objectives start becoming common across these multi-sectoral parties, and when the business community has this in their priorities. And I think we'll do that through these other channels. So my additional comments are really that we need to build this strategy of outreach and alignment on goals and objectives.
Seems that, with the death of Margaret Thatcher, I was reading her obituaries, a very strong-willed, controversial figure, and I recently saw the movie. Seems that what I took from the news accounts in the movie was the fact that she was a rare politician in terms of a point of view, and that most politicians follow the public's opinion. Seems like political will follows public communication and movement, if you will. So I think that question, and I'm adding my own comment here, sort of needs to be deconstructed a little bit in terms of where the opportunities are for a roundtable, in terms of creating communication that feeds public will, that backs up to something broader than that. So an ambitious topic for the roundtable, an ambitious task might be the conclusion. But anyway, that was my own little comment there. George?
Feinberg admonished us to keep in mind what it's focusing on what's feasible. And we know the pathway forward is probably going to be more feasible if we have early wins. Could you comment on what you think might be some early wins?
Panel on early wins. Cathy, you want to start with early wins?
Yeah, well, that's where I was headed with my comments about look at those things that are have already declared and defined that they're trying to focus on improving population health and figure out how to help them be more successful and more insightful on doing that. And I think those are at least steps in the path of the trajectory, and they have immediacy.
Okay. Others, early wins?
I think some of the early wins are in the area of having a simple dialogue and letting people know where they stand in terms of healthy life expectancy. I think people are very compelled by rankings and where they stand and how they do versus others. The county health rankings are one way to get us there, and I think if we have a standard metric, and I don't think it's all that impossible to do, to get it at a local level so that we actually can begin to talk about our counties, our states, will help motivate people and let them know how far we have to go. And I enumerated a whole variety of interventions that are out there where the money could be allocated and do better. I don't know how many of them are going to resonate with people in terms of getting resources, but as others have said, we already know a lot of what we need to do, and some of them should move forward.
I would just add that there actually are a lot of examples of really rigorously evaluated, relatively simple policies that work to improve health, including population health, and that actually save money. Whether you look in the area of early childhood investment, whether you look in the area of improving neighborhoods and communities, County Health Rankins has many wonderful examples of communities that are making a difference. I think one of the things that happens is that these things happen in some isolated corner. They're not elevated so that most people aren't aware that it happens, and people elsewhere in the country are trying to reinvent the wheel because there isn't a one place you can look to and see all the array of possibilities there are. So one of the things is to even raise the awareness level of what works and how it works and how it can be implemented so that we can get a higher take-up rate of a number of strategies that have been evaluated and that actually show benefit in terms of health and also in saving cost.
I guess I would add that there may be easy wins. There are, I would agree, easy wins that have been, or wins that have happened, have been identified and characterized. The challenge for us is the scale up and scale out. The challenge for us is having the resources to scale up and scale out, because sometimes it takes a bit of an investment. But I would agree that raising awareness, demonstrating those examples of what has worked, finding the places to have those conversations is part of how we get there. If indeed reallocating shared savings is a strategy to pursue, then we also have to identify some easy wins that resonate with the medical care community. And one that comes to mind as I sit at this table with individuals on both sides of me who are members of the National Commission on Prevention Priorities, there is a story to be told about investing in, or more importantly, identifying those clinical preventive services that have high impact and cost effectiveness, challenge ourselves, challenge the medical care community to do a better job. And there are a handful of those that are very compellingly cost savings interventions, and begin talking about a mechanism to redirect those dollars upstream into community prevention.
I would add that I think how you define early wins depends on what your goals are, and if the goal is to highlight case studies that where successful models have been implemented, I think we could, the Roundtable could do that. Others have done it. There are clearinghouses and other efforts that are being undertaken. But I agree with my colleagues here that if we want to be bold, it's taking it to the next level. And an early opportunity, I don't know how easy it would be to win, but I think an early opportunity that's low-hanging fruit and very timely right now is that we are in the midst of a national discussion about our fiscal challenges, where decisions are being made right now to take policies that have the potential to improve population health and not only not increase the spending to the level that the other high-income countries do. I showed you that chart earlier from Elizabeth Bradley's work, but to actually cut them, to pull back on those. The argument being made, we can't afford it. And one early win would be to change that conversation and say we've got plenty of money, which would be a dramatic claim to make, but the fact is, if you look at our GDP spending on health, we spend way more on health than any other country. So we have an enormous budget that we allocate to health. So we as a society are prepared to spend a certain amount of money on health. It's how we choose to spend it. So beginning to have that kind of a conversation and making the kinds of economic arguments that Steve Teutsch and others have made about how that money could be reallocated, I think is an important first step. There's all kinds of political backlash and crosswinds to deal with in doing that, but I think it's key. The other self-serving early win that I'd want to see accomplished is for people to begin realizing that we not only don't have a world-class health system, but we don't have world-class health. And if American parents were to understand that their kids are actually not going to live as long and have greater disease rates, and that was part of the reality, then I think that would motivate different changes. The point David made it about communication, nowadays we say, you know, go green. If you're in the store or choosing a product and you see those two words, that means something to a consumer because there's been an acceptance of the idea that our environment is in danger and this is a way for me to deal with that. So those types of communication strategies have been built on greater awareness and consciousness about a threat. So having a greater awareness of the health threat that our population is under, I think, would provide a foundation for more effective communication strategies.
Okay, next.
Paula Lance from George Washington University. I want to continue this very interesting and productive discussion and push it a little bit further. So all of us in this room know that health and healthcare are not the same thing, and that health disparities and healthcare disparities are not the same thing. My worry is that as this grand experiment we're undergoing right now in this country, the rolling out of the Affordable Care Act, which a lot of the key provisions are going to start coming on board next year, I'm worried that, and I don't know if anyone in this room thinks it's going to be a simple implementation of the new marketplaces and the states are going to roll out Medicaid. I mean, there's going to be bumps in the road and there's going to have to be recalibration. And I think we already struggle with the discourse that health and healthcare are not the same thing. There's going to be an incredibly crowded space for public discourse, for policy agendas, for resource allocation as the Affordable Care Act rolls out. And not that I'm Chicken Little and the sky's falling, but we know we're going to have primary care shortages. Living in Washington now, the growth of concierge medicine here is astounding. And I think we're going to have really not even maybe a two-tier healthcare system, but even more tiers. I think healthcare disparities are going to be exacerbated before they maybe get solved. We know health insurance premiums are probably going to go up before they go down. So I do sound like Chicken Little, I guess. But anyway, and this, again, this idea that we're rolling out a huge health-related endeavor right now. How do we not just put on the back burner and sort of wait till this rolls out the important message that population health and health are different from all the things that might come out of the grand experiment?
Anybody want to make a comment
Well,
to that?
I'm happy to try to jump in and get us started. I do think that what you are talking about, I think, is a concern that's shared by many. I think that perhaps the work of the Roundtable is to begin to think about maybe framing a conversation around some of the things that Stephen was talking is, where do you invest first? And if indeed there's going to be this sudden game-changing event called the Accountable Care Organization, whether it is the fact that people are going to be seeking primary care, may not be able to get it, we can focus on that, or we can step back and say, what is the objective of the primary care in the first place, if indeed it is about health and not just about signing someone up to a doctor. Not that that's not important, but it's probably not enough. It may create the space to have the conversation that says, what are the things that we might invest in first? How do we do investment in healthy community even while we're trying to deal with this engagement of new patients into systems conundrum that's going to be created? The other part of it is accepting that there's going to be medical care that's going to be delivered. Again, how does one step back and say, what are the things that make sense? And I'm sure that folks in this room are familiar with the notion of choosing wisely, the movement. Perhaps there is a movement around choosing wisely that also has to do with what ought to happen in primary care, what ought to happen as it relates to population health, to provide some guidance in how we invest those dollars. I think the case that Stephen on this side of me, that there's the dollars are there. It's a matter of allocating those dollars in a way that makes some sense. Maybe an opportunity for the Roundtable to step back, and in a way that is not about choosing winners and losers, is a way about framing the objective to be improving health, and then how that allocation might make better sense than the way we do it. Again, I think this, Stephen, certainly started that process this morning.
Of course, the Affordable Care Act was about more than just the clinical care system. It actually had a very strong component, as all of you know, in trying to strengthen the whole concept of prevention. And those provisions, although there have been efforts to take the money away, haven't gone away. And Steve Woolf pointed out the National Prevention Council, which is really pulling together all the federal agencies to think about a health and all policies agenda. Granted, they've been focusing a little bit more on the clinical, but the real purpose is to get into a health and all policies agenda. Can continue sort of independently of what all the turmoil that's going to happen in the affordable care in the clinical care system. I sit in a local public health department, and I can assure you, we're undergoing big changes. And I think it's not going to be easy for us either. We're still, I don't know if anybody's listening, sort of stuck in a 1970s model of a largely clinical-based public health, service-oriented delivery public health system. My own belief is if we're going to transform into a contemporary system that really does primarily look more broadly, we have a unique opportunity here, as many of the clinical care services can be transitioned in, over a reasonable period of time to the clinical care system. Our public health system needs to take advantage of it, and this is the sort of the message that was in the Public Health Strategies report that we've referred to a few times, that we need to really rethink about reframing what those organizations do, empower them to bring the appropriate stakeholders together and actually begin to deal with population health much more than they have, which has been focused, unfortunately or fortunately, because it was needed, on many of the individual level services. So while I understand we're going to be distracted by all of the really important changes on the clinical care side, there's plenty of action on the population health side I think we can capitalize on.
Cathy, did you have a comment or not? You don't have to. But.
Nothing to add.
Okay. I would just make a comment. One we've got, I think I've identified in our first phone calls, Roundtable, that an early target of the conversation might well be, and we'll have more conversation later today and tomorrow, might be actually looking at some of those opportunities in the ACA. That's number one. Secondly, these comments really suggest to me the intimate relationship between, Steve, what you're talking about, changing the conversation to we've got plenty of money, but it's hard to pick it up off the floor if it's laying around, because you have to change the nature of where it's currently spent. And so there's an intimate relationship between those dollars and re-engineering and mobilizing costs and the public's perception about that, which I know Sandy Magnan has been working on in Minnesota, and actually mobilizing it for investment. So that also is a big, big challenge for us going forward. Go ahead.
Morning. Jose Montero, I'm the Director of Public Health, New Hampshire, and the President of the Association of Resident Territorial Health Officers. Great presentations. I have like 300 things that I want to say. I'm going to try to get them down to maybe 5 or 3. We keep talking about waste, and recently, people like me sit at the interface of public health, academic world, and politics. And it's a really funny place to be, because we are talking about saving money and changing delivery models. And I was reminded that my savings are somebody else's job. So nobody will accept the term waste for what I do for a living when I have such a strong commitment to what I do and improve the health of people. So when we talk about messaging and the way that we use our language to bring others to the table, that is a tricky message. So we need to be incredibly careful and mindful of that, even though philosophically I agree with the statement. but it's just an issue of how we frame it, because I tried to change a few things and I couldn't, because that will mean that we need to close a service that will lay off 5 people or 10 people in times of crisis, and we're always in a time of crisis. But then I look at this, and somebody said that we need to build a political coalition and get some early. Most of us are quite not really politically savvy in creating those coalitions as it goes external from our world. So how do we bring those who have that expertise? How do we bring those who speak the political language? How do we learn from them and use that language to advance the agenda of what this group is going to be doing is quite important. And then this other message about that we have too much money, it worries me because every time that I go and get my budget approved, somebody reads that we have too much money. And I don't. Somebody else does. And then when I want to propose something on prevention, they said, okay, so I'll cut your budget today because you can do prevention. So where is the difference between return of investment and cost avoidance? And how do we bring that different framework of thinking in our public discourse, and how do we explain that we're changing the redistribution of that system? Because if we talk about savings, means that we are not going to spend it, so we are not going to have the whole dividend that is being proposed, or we're not going to have anything else. So it's an issue of reframing a little bit the language that we're using. And my last comment, I want to challenge a statement that I just heard. I don't think that we have a shortage of primary care. The problem is that we have a system that is ill-designed and based on physicians, and it shouldn't be. When we look at the future, and we look at the chronic conditions as the main conditions that are affecting us, and the research that is telling us that we do a lot of education and behavioral modification that are going to prevent those diseases, it would be ill-advised to have clinicians with 12 or 16 years of training doing that education. And if we are going to really change the agenda and decrease the cost, and we're looking at primary care, shouldn't we change that framework? Maybe what we have is an excess of other specialists that are not in the primary care field. But when we look at population health and we define our goals, how do we look at the resources that we are creating for the implementation of the system that we are dreaming? I don't have the answer to that, but I would love to pose that question to this group as part of the discussion that we are going to engage in. Thank you.
Thank you. Any comments here? Go ahead, Steve.
Well, I'll take the easy one, the ROI one. And I'm actually troubled by that term. I don't have any problem with cost benefit, and I don't have any trouble with the concept of return on investment to society as a whole. But I have big trouble with the concept of ROI as we tend to use it, which is in my mind is primarily a financial term. If I invest, how much do I get back? And it is rare. It is extraordinarily rare for a government to invest in something and then get a true return that you can directly relate to it. And it's probably true in education and in other areas as well. Societal net benefit is positive, but the return on investment in the sense that you're going to save money so that you can reinvest it in something better and make more profit is just not, it's just a transference of a business concept into, I think, an environment where it's about social benefit and societal benefit, but we don't have that that construct. So I much prefer terms like cost benefit, cost effectiveness, value, although value is pretty vague, than terms like ROI. In fact, I'll call your attention to a report that was completed at the end of the year, last year, on how do we value community-based prevention. And it really does lay out a framework for thinking about the dimensions of value and how we begin to capture that. And it lays it out basically, not only in terms of harms and benefits to the individual, to the community, and in terms of deliberative processes and strengthening the relationships. So, as I said, I took the easy one. I'll let the communicators and others deal with it.
So I'll talk about two things, because that was a great set of thought-provoking questions and comments. One is as it relates to waste. Having done what I've done for the last 5 years, I don't think that it's unfair to characterize spending money on interventions and services that are not evidence-based and are not going to deliver anything related to the triple aim is worth calling out as waste. The other is that we calling things out that are a reflection of poor coordination and duplication, I believe, can be called out as waste. And the IOM report points out those places where I think there's tremendous opportunity, and it has been my experience that kind of over expenditure can be extracted from the system, and health plans are trying to figure it out. what they're doing right now when they accomplish that is they are actually selling that waste extraction, if you will, as a ROI to the employers who are buying insurance from these health plans. So there is a robust effort to extract that waste. We've got to insert ourselves in the conversation that says some of that shared savings has to move upward so that one can achieve a greater population health improvement. The other point that I would make is that you talked about the intersection of public health, academics, and politics. And in the part of the world that I'm in, which is a very red part of the world, you got to start with the value proposition in terms of dollars, not the value proposition in terms of philosophy. And so I agree with you, Steve, that it's illusory to be talking about ROI, but sometimes the only way to the table and in the door and to the table is to frame it as a business proposition, not necessarily the right thing to do from a political or philosophical standpoint.
I don't know, Cathy, do you have a comment to make at this point?
Yeah, well, I think it was a very important comment and something that's been on my mind. I completely agree with the fact that we have things that should be called out as waste, but I do recognize that there's some hazard in doing that, and that, as was rightfully pointed out in the question, that waste is somebody's revenue, and that those folks for whom that's their revenue, how do you find a way that they can be in this game and not feel that they're just, it's a win-lose proposition. So how can those health systems become more part of the solution than part of the recipients of the revenue associated with the waste? Can they create new business models, new service lines, mechanisms where they can be brought into the solution space rather than feeling that somebody's just out to carve out a chunk of their revenue? And I don't know the complete answer to that, but I do realize that those that are holding all of that revenue, that represents nearly 20% of the GDP, are going to be very interested in what's the strategy here and how are we going to find mechanisms to get enough allies, and whether they can be an ally or not an ally, I'm not sure, but at least I would want to put some energy into trying to figure out how we can go forward without getting ourselves caught in the crosshairs of a challenge with those powerful forces.
I'd like to build on that to just say that without getting into the question of how we should frame it or what messaging to use, is the larger point that I think the comment made about how we need to think about how we frame these things and how we message it. And I would hope that the Roundtable would reach out to people outside our field who are really good at this sort of thing. My vision is that we need to move toward a triad that combines the academy, and I'm using that term in the broad sense, with the policy mavens out there who are not necessarily savvy about the research, but understand where how these decisions are being made, what the major drivers of these decisions are, the realities in the various decision environments they work in. And the third part of the triad are the communications people who don't necessarily know the policy world and they don't necessarily know the research, but they know how to market a product. And if you put those three together, and two of those three don't typically circulate in our world, but if you bring those three together, I think we have the power to marshal what we know about public health and population health, to push buttons that are really going to move the needle in terms of actual policy, and to be effective in packaging it and framing it in a language that's compelling.
I want to add to your comment, Steve, because as I heard your comment, you mentioned the change and language, the change issue and the language issue related to change, as well as political connections. And then you ask, how do we learn from people that already are expert at this or have used this? And David Williams, in your talk, you mentioned some very clear examples of where there are examples of people who are beginning to make a difference. There are other situations we can learn from. And I just want to draw attention to the fact that what Harvey talked about in terms of this being a forum, he used the word forum when he was talking to us. He didn't use the word consensus study. He didn't use the word conclusions. He used the word forum. And when my own knowledge of this is evolving, but to my way of thinking, if we're smart enough, we'll be able to engage those folks who have these lessons and know these lessons through the way we structure our conversations and our activities as a roundtable, as a forum. And so we ought to, particularly those of you in the room who are going to be having this discussion later today and tomorrow, ought to be thinking about that very process of how we widen the pool, how the ripples go out, how we engage others so we can learn the lessons that I think this very important question really poses for us. That question of how do we learn from them, how do we incorporate that in a strategy that makes a difference is really central to some of the roundtable activities that we've got in front of us. Who else wants to make a comment or a question? Go ahead and step to the microphone, because we're on the web.
George, as he's stepping up,
Go ahead.
I do think there's framing things as winners and losers is probably not a winning strategy long term, right?
Right.
But perhaps there is something to what I said, which is that the burden of chronic disease and the aging of our population in the short and intermediate term will probably, from a financial standpoint, keep health systems and hold them somewhat harmless. If the idea is let's build more and more and more capacity, maybe that's a different conversation. But to hold steady while we re-engineer the system and begin to identify those shared savings that can be reallocated to upstream populational health, it may be a way to have a friendlier conversation that isn't about strategizing to defeat or to stop or to in some way get in the way of.
And again, already in our early going, we've identified this issue of mobilizing savings without generating resistance that's major or fatal. And then obviously the second question is the mechanisms for reinvestment that Steve Woolf and Steve Teutsch and Martha in the audience know is with the report on investing in public health. We're having a little trouble sort of figuring out that argument for how you raise revenue for investment at the same time you're encouraging efficiency. So that's another kind of real problem that we have to take on. Go ahead.
Sure. I wanted to pick up on this theme also, especially the issue of what do we do with the folks.
Introduce yourself.
Oh, I'm Jim Nickman from the New York State Health Foundation. And I want to pick up on the theme of again, what do we do with the folks who are already spending all the money and sort of cutting back. And just a couple things we should really commit to, I think. And one is that, the whole argument that healthcare produces jobs is a funny argument in economics. The truth is, building boats creates as many jobs as spending money on hospitals that you don't need, and maybe people like boats. I mean, it's sort of jobs happen with economic activity. Now, there is something really nice about healthcare jobs, and that's because they are in communities, and they stick in communities. If you build boats, they're all going to get built in South Carolina and Florida. And if you have healthcare, the jobs are in a good place. So that's important, but it's different than just jobs. It takes jobs and employment to keep people healthy and to do population health activities, just as it does to do unnecessary health care. It's still jobs. So you come back to the transformation can't be us, them. It's going to be Montefiore Hospital in the Bronx that leads the way. It's going to be Maimonides hospitals in Brooklyn that leads the way. We just have to transform them from doing medical care to doing population health. That's what every American corporation has always done. They don't produce the same things century after or year after year. They transform themselves. So what we have to do is help these organizations and these entities, I think, transform themselves. And of course, to me, my economics background, it's all about payment. We have to, and this is where it all comes together. If we pay Montefiore, $3 billion a year to take care of the health of a big chunk of the Bronx, they will figure it out. The same way the auto industry figured out when Toyotas and Hondas came in that were cheaper and better, they figured out how to transform the car. It took them 20 years, but they figured it out. And I think we have to count on Maimonides Maimonides and Montefiore figured out after we give them a capitated amount of money that allows them to spend money on keeping people healthy as opposed to recovering them. So just, I hope we can come back to that.
Martha, I saw you shaking your head.
It's a great opportunity to be in a room where I can shake my head and feel comfortable doing that.
Introduce yourself.
Martha Gold. I guess I'm concerned that there are two different levels that we're talking about. And one is the area where, in fact, we really do need an evidence base that says if you do this population health intervention that improves nutrition, that improves exercise, that greens up the neighborhood, you're going to have some more health, right? And that evidence base is still a little shaky. And so in a way, we have our hands out asking for money for something that we don't have a great evidence base. We have good instincts. We've learned from the things we've known before. We're pretty sure it's going to work, but it's a harder argument to make. And it's also a harder argument for me to think about medical care systems making that argument, particularly when there is a public health infrastructure that has the skills and has the knowledge base. It's sort of the issue of the rich getting richer, and I'm not sure that the right rich would be getting richer in this situation. But to me, the larger worry is that I think many people in this room believe that what we really need to do is redistribute wealth to redistribute health, right? And that argument is a much more challenging political argument to make. And one of the things that I guess I'm wondering about in this roundtable is whether we're going to try and think more at the one step up level, at the sort of meta level, or whether we're going to the Uber level. The Uber level is where the payoff is, but it is, you know, the deeply challenging piece.
So comments from the panel on the little dialogue here between the two questions. No further comments. You've set up I think, a very interesting conversation there about how we get to which endpoint, and we've got to have a conversation about endpoints. I will say one thing about the us-them comment. You know, Eduardo, in your introduction, you talked about coming from the dark side, and the language.
But I made clear that
Yeah.
I didn't necessarily agree I was there.
Really?
I'm still paid by Blue Cross Blue Shield for 4 more days.
But roundtables are actually structured and need to be structured so they bring in all points of view. And because if we're going to talk about improving population health and it requires political will and public engagement, then indeed we need to engage a lot of the different points of view in the dialogue and the conversation. And so there are, in a sense, no dark side to the conversation. There are different sides. And the challenge is to create that common engagement across all of those. So I would just make that observation, just a personal observation from just hearing that. And language, interestingly enough, is a very direct manifestation of subcultures, whether they be public health subcultures, healthcare subcultures, and so forth. And when you're in them, it's hard to understand where you are and see the culture, but you can see the other cultures very clearly. So I think this will give us an opportunity actually also to engage in learning about these subcultures and how we should change them or modify them or deal with them or understand them or respect them, all those things perhaps, in order to reach some common points of view. So there's some real challenges there in that comment and in that dialogue between the two. Why don't you go ahead and make a comment or a question?
Thanks. Hi, I'm Bob Hughes from Missouri Foundation for Health. And these comments are great. They take me back to graduate school seminar. I'm really thinking about the high-level ideas. And I wondered if you all could talk a little bit about some things that were, some points that were made that are more kind of on the ground in some of the prepared remarks about implementation, and more at a local level or community level, and what, if anything, you envision that component of the work over the next 3 years, how that might unfold and how that might be connected to some of the arguments about what our ultimate goals should be in our time horizon.
Cathy, do you want to start the answer to that question?
Well, I will, and I'll link it to the past couple of comments in that we are still often in this conversation talking about, well, we've got the healthcare system and the public health system, and we keep referencing these two systems, and one's got money and one doesn't, and you know, one has certain knowledge and the other one has different assets. And in my comments, I was asking the question, well, okay, what's our vision? Are we going to unite them? Is there some framework or some system or some process that actually is going to bring them together, or do we see them just as sort of isolated, going down parallel tracks here, and each having sort of their separate set of duties? Or is there a newer model where we're united in some fashion by a framework that helps us work as a macro system, really for the benefit of the population? And I think we're going to need to think about that space in order to make real progress here and get to implementation. And as I mentioned, I've been actually working on the ground on doing this in this 14-county region in central Michigan in the last 5 years. And it's really been important to bring these parties together, although sometimes frustrating and sometimes you wonder about the wisdom of it, but bringing everybody together, saying we collectively need to own this effort, and we need to recognize that our sustainability and the capacity of our community to thrive and be successful is really dependent on our ability to take hold of this at the local level and make a difference. We're getting some feedback here. But I think that's where we're going to need to continue to understand what works and what our opportunities are.
Thank you, Cathy. Other comments on the ground, near term, real world, tangible?
I mean, there are other examples out there. The AAA does talk about an integrator, as a group that pulls these things together, and there are examples around the country. The folks in Minnesota can certainly talk about what they've done up there. In Memphis, it was the churches that pulled a lot of this together. In Akron, it's the business community, or biotech community, I believe, that have really pulled it together. I don't think the model looks the same everywhere. But you do need these key organizations. We've talked about public health playing that role. Not in every place they certainly can't do that, but in places they can. So I do think that this concept of integrators. Cell phones? I don't know. I'll turn it off. At least it's not ringing. Anyway, these integrators at different levels might be able to pull some of this together, and it'll look different. But the one thing they seem to have in common is a sense of creating mutual accountabilities and shared accountabilities, and we describe that in the measurement report, right? Measurement report on public health strategies. So that's some ways to think about it.
I would go back to the comments that I made, and I think there's three very concrete examples. One is relooking at tobacco control. It is a way to frame the issue in terms of comprehensive, multifaceted approaches that include many other components that contribute to health, but also including the medical care system. The coordinated school health program that I mentioned is one that bridges the health community and the education community, I think in a way that strengthens the argument that fit kids are smart kids. Smart kids become smart adults who support fit kids, and there's a nice cycle there. And then lastly, the Diabetes Prevention Project, which I see as a real opportunity to take both medical care in making that diagnosis that someone's got prediabetes, but recognizing the capacity and the ability to take care of that is in the community with health promoting interventions. Those are three very concrete examples. There's cost associated with those that can be compared to the cost of other medical interventions, can be put in a context that I think makes it easy to understand what it would take to get to that place.
Other comments? Okay.
Hi, Judy. Can you hear me? Judy Monroe, CDC. Just a comment about previous IOM reports. I'm here to report that CDC is working with HRSA and with CMS closely that have been recommended from some of the previous IOM reports. My question or my comment is that one of the things that we are currently doing now is working with the Centers for Medicare and Medicaid Innovation. As I hear about, immediate opportunities, just April 1st, there were 25 states that had funding coming from CMMI on the State Innovation Model Awards. 6 of those are in the testing phase. We have 16 states that have 6 months to design their system that then, if successful, might get funding for testing, and 3 states that are revising their design. So it seems to me there's an immediate opportunity here and I'm wondering comments from the panel about opportunities that you might see that the Roundtable can seize this immediate and urgent opportunity where there is funding.
Great suggestion. Thank you. I'm thinking that at this point we should turn to the public comment, unless there are anybody want to make a comment to that, but
the only
go ahead, Eduardo.
The comment that I would make is that we've crossed the chasm regarding universal access to health care and the willingness to acknowledge that a significant per capita investment will have to be made to do that. And it might be one of the tasks that the Roundtable might take on is the notion of access to health and coming to some consensus about what it will take to adequately provide that access to health. As a former state health officer who had to compete for dollars for programs that every single state should have gotten some allocation for, we operate in this deficit mode and we don't provide enough resource to blanket and cover the need that's out there. That's probably part of the conversation that needs to be had. It's got to be adequately funded, and we can't operate always in let's test things and then fund them up, because my experience at the state level anyway is you test it, you demonstrate it, you prove it, it ain't getting funded. And so how do we have the conversation that says let's be robust about the dollars needed and then work our way to using those dollars wisely?
Other comments before we move on? Okay. Go ahead. I'll take a question.
Thanks. Mary Pittman from the Public Health Institute. There's so many things that we could take off on, but there's a lot of conversation about implementation and implementation science. There are a lot of great examples. I think Eduardo just pointed out that often a evidence-based example does not get funded, so it just kind of lays there fallow. So I think we need to be thinking about how do we really cull those good examples and figure out what's the implementation science that can be applied to scaling up when we know that there is a good social return on investment at a minimum and a business return on investment as well. But it also pushes us to think a little differently about what implementation of population health needs to be in the future. I think about how different age groups, different cultures, take messages and act on them. And I'm thinking, for example, of my sons who receive information very differently. If I haven't texted it or if they haven't gotten it on Facebook, they're not likely going to receive that message. And I think we have to be learning savvy new tools to get the message out to, different population groups and the folks that are necessarily sitting in this room. And so I think that's one of the issues that we're going to have to take up in our conversations going forward.
Excellent point. Any comment to her point?
I would just want to agree with what she said, but also emphasize, I think I mentioned this in passing, that we also need to think of what are the infrastructures of support that will be in place. We're not going to get the message out 1 week after you issue a report and then the work is done. We need to have infrastructures in place that would be constantly scanning for the opportunities. There will always be opportunities where we can get a message out and where we can sustain the momentum and where we can keep a steady drumbeat of information, where we can keep before the public the new information. We're in this media enriched world where people's attention span is very short. And if we don't have in place infrastructures, I mean some infrastructures that will do the work and look for the opportunities and maximize them, it's not going to happen long term. So this is a long-term strategy. I think Javi correctly said it, that this is a long-term strategy. We need to think of what are the long-term infrastructures that will support and maintain this. America has a very short memory.
Excellent point. And I think with that, I think we should thank this panel terrifically for helping us getting us started here. This panel really has indeed, I think, helped us to begin a conversation about what our task is and how we should proceed.